guys can see you.
Okay.
Microphone down?
No, it's silent.
Oh, not at all.
Oh, weird. It wasn't turned on. Okay, we're going to start again with good afternoon. And welcome to our noon session, Is Healthcare a Right? I am Ruth Katz, Executive Director of the Health Medicine and Society Program here at the Aspen Institute. I'm also co-director, co-producer of Spotlight Health, which is the first 3 days of what is now the 10 days of the Aspen Ideas Festival. For those of you who were there, I hope you had a great time. For those of you who weren't, I hope we'll see you next year. It's my pleasure to introduce our interviewer for this session, David Leonhardt. I'm sure many of you know that he is the op-ed columnist, an op-ed columnist for the New York Times and writes a daily newsletter, Opinion Today. David was previously Washington bureau chief and founding editor of The Upshot, a New York Times section covering politics and policy. He has also worked for Business Week and The Washington Post, and in 2011, David won a Pulitzer Prize for his commentary on the financial crisis and its aftermath. I'm delighted to say that David is also a very good friend of the Aspen Institute. He serves on the jury for the Aspen Prize for Community College Excellence and just finished a few days with us at Spotlight Health. So thank you all for being here. David O'Toole, great to have you here. Thanks so much. Enjoy, it's going to be fabulous.
Thank you, Ruth. Thank you all for coming indoors on this spectacular day. We'll get you outside when it's over. You, I'm sure, all know Dr. Atul Gawande. Atul is a surgeon at Harvard. He runs Ariadne, did I pronounce it right?
Ariadne Labs, yeah.
Which basically tries to improve the performance of healthcare using large-scale experiments. And he's a writer for The New Yorker. And since that really isn't enough to do, he recently became the chief executive of a new healthcare company that is going to combine employees from JP Morgan, Berkshire Hathaway, and Amazon and try to improve delivery of healthcare for those employees. It'll be a nonprofit, right?
It's a nonprofit, and the aim is pretty straightforward: improve the outcomes, improve the satisfaction with care, lower the costs, so better cost efficiency, and to do it in ways that create scalable models of delivery, so incubating new models of delivery of care that could reach much more widely.
That others could do, that other companies could potentially copy.
So not only to serve these employees, but ultimately create models that could work widely, ideally for everyone with time.
So we're going to base our conversation around a question. Atul and I are going to talk for a while, and then we'll open it up to you all as well. And we're going to start with this question, but we'll expand to talk about all kinds of things around healthcare. And the question is healthcare a right? And what's interesting about this is that if you look around the world, this isn't a question that in most of the rich world, Europe, Japan, Australia, Canada, people grapple with. Universal health care in those countries is just an accepted fact of society. But in our country, we linked the provision of health care through health insurance to employment because of World War II and caps on wages, which then led to the spread of health insurance. And we had this somewhat accidental situation in which if you're not employed and you don't fit a number of other categories, you may not have health insurance and thus health care. And so Atul went home to southeastern Ohio and asked some of his old friends and some other people in the community this question: do they think of health care as a right? So I just want to ask you to start by talking about some of the answers that you heard there and what that caused you to reflect on. This article originally appeared last October in The New Yorker.
Yeah, so I'm from Athens, Ohio. It's the poorest county in Ohio, but has a college sitting in the middle of it. And when I go home, you know, that district, that region all went red for voting for Trump. And so when I went home, you know, I'm a public health guy, right? So I come from the left. And so I just avoided politics when I went home. And this time I decided when I went home, it was in the throes of the latest fight over healthcare, to get past the politics and just say, what do you think? Do you think you and your family deserve a right to health care? And the really interesting thing to me was the number of friends, the vast majority, by far, like it was only a tiny number who thought we do not have a right to health care. I mean, this included 3 people I knew, and then, as I started asking around, I asked my friends to introduce me to some of their friends, and so the ring got wider, and 3 of the people I ended up talking to were bankrupted or near bankrupted by healthcare costs. And they said they did not think that it should be a right. And as I probed it and came to understand it, I realized that there is a core dilemma at the bottom of this, because they do not think that when they hear the story of we're going to make healthcare right, they hear it as a demand on them. They are the average taxpayer, and I think we don't understand that. The average taxpayer does not have a college education. Only 30% of the country has a college education. So the average taxpayer, like my friends back home, have a high school education. They are, the per capita income of the median taxpayer is $33,000. So, one example of this person is Mana French, who graduated the same year as me from high school, and now is our school librarian, which is classified as a clerical job. And so she has a bachelor's education. She's an incredible volunteer in the community. She raises money for the volunteer firefighters, everything else. 22 years on the job, she now earns $16.50 an hour. She has a health plan now that has a $3,000 deductible, and she doesn't have $3,000 in the bank. Many of you know the statistics that it's only 40% that have $500 or more in the bank in accessible cash. So, another person I interviewed was $6,000, and they'd been bankrupted by healthcare costs while carrying insurance that they consider pretty good insurance. So what Mana sees, and what the other people I talked to see, is they are paying she pays half of her income in taxes and in healthcare premiums, are going bankrupt because of healthcare costs, and their taxes are going to pay for people in the neighborhood who do not get the deal that they get. Those people in the neighborhood, they're not working, and they get Medicaid, which is better coverage than they could ever dream of, than they could ever pay for. No copays, no premiums, no deductibles. And so what they say is, you liberals, you don't care about my life. You don't think my life is actually of equal worth. You talk about the idea that people's lives are of equal worth, but their lives are not of equal worth. So you say you want a right to health care. Well, who else am I going to end up paying for? I just know I'm going to get screwed in the end. And that was where the discussion started. But I did think there could be a bridge that came out of the course of all of those discussions.
When you look at what the Affordable Care Act did, right, to overgeneralize, but only a little bit, it had 2 major expansions of healthcare. It expanded private insurance and basically said we're going to subsidize you and let you buy it on these markets. And it expanded public insurance through Medicaid. One of the reasons the Obama administration did that is they wanted something that was a mix of right and left, right? But it seems to me the left half of that has been a lot more successful than the right half of that. The Republicans have fought both halves of it equally and have actually succeeded in causing the private markets to not work so well. When you look at the polling, there is deep support among both Republicans, people like from your hometown, and Democrats for government-provided health care. Is that likely the future of health care for growing numbers of people in this country, Medicare or Medicaid?
Well, so it has been interesting to watch the battle over the government expansion side of this, because it isn't wholly popular. It's just more popular than the exchanges, right? And so what people have seen, we're seeing is the battle happening now. So Medicaid did expand, and it transformed from a welfare program meant to be either for poor children, the disabled, or and pregnant women, and then started to expand in many states to be coverage for, sometimes it's seen as temporary assistance for the poor, people out of work. The coverage under the ACA allowed us to say, look, everybody who is poor at or near the poverty line would have that coverage, that it no longer was about it being a welfare program, it was about it being a program for people at or near the poverty line. And then when it expanded that way, it did lift a ton of people. In fact, it's a bigger program now than Medicare. Medicaid is 70 million people. Medicare is 50 million people. So we're at a point where 1/3 of people in the country, in surveys, know someone personally in their family or close circle who are benefiting from Medicaid, and that it is providing an important safety net. What people don't recognize, so it is the disabled child, it is the elderly parent who's gone into a nursing home and then spends down their savings and then ends up on Medicaid. It is and now it's people who are at or near the poverty line who are getting access to care. Now the thing about Medicaid is it is very generous coverage. It is dental, vision, comprehensive benefits, even transportation to and from going to your medical appointments. It is no copays, no premiums, no deductibles. And so part of what's been unleashed is this stark contrast. If you're on the other side of that 133% of poverty line, you're at 134%. You now go into an exchange where the average deductible is over $2,000.
Those are like the people you were talking to back home.
And then you have the premiums, and then you have everything else. So we now have this battle over work requirements in Medicaid. And in the blue states, they're not moving in that direction because they see it as a program they want to expand. In fact, Nevada voted, and it's not even quite a blue state, last year to create a kind of Medicaid for all, to allow Medicaid buy-in according to your income. So you could buy into the coverage. And the governor hemmed and hawed for a little while and then vetoed it. But it's one direction that we go. So the long story short, I think that the challenge has to do with it's still understood as something that is not open to all, that average taxpayer is paying for, that they feel they don't have access to. Healthy Indiana, which went into place, and Mike Pence as governor supported, is a really interesting thing because what it said was they expanded Medicaid, but they included the idea that above the poverty level, you're paying something in, as low as $2 a month in a premium. And we've had tremendous battle over whether that's right or not. But what I'll remind you is in Medicare, we all pay in. We all pay in through a payroll tax. And I don't think there's anything fundamentally wrong. In fact, it is probably the more successful system that everybody is paying in something according to income, because then we all feel we are all paying in and we're benefiting fairly. So, I don't think that things like Healthy Indiana are necessarily the wrong way to go.
This is my summary of your work, not yours, so feel free to disagree. But it seems to me that when you look at the evidence, what's happened when states have put on the ballot, should we expand Medicaid? They pass, right? When you look at the poll numbers on people's attitudes toward Medicare, these kinds of universal-ish healthcare programs are actually quite popular. And the anger out there and the version of no, healthcare is not a right is about fairness, is about I'm paying too much for my healthcare, right? And so is the ultimate solution trying to move toward a system where people feel that things are less varied and that they have at least an option to buy into that program or enter that program that they think unfairly goes only to others?
Yes. So you started with the World War II mistake,
yes,
right? And it's worth understanding how that has ended up creating this place we've ended up in. When we shipped off a large part of our workforce to fight overseas, then in order to avoid labor inflation, they imposed labor wage controls, so freezing wages. And then employers said, we need some flexibility, so the government said, well, you can give people health insurance. And once we opened that door, that became the main way that people got health insurance in the country. The first way people got health insurance was through their employer. And once we did that, then we said, well, let's build the rest of the system around it. And so we said, well, over retirement age, we'll create Medicare. And if you're not employed and you're poor, we'll create Medicaid. And if you are a small business, well, you'll buy it on an individual insurance market, and we'll create all of these different groups that will have different kinds of benefits, disability coverage, everything else. And so it's been this hodgepodge around the system. So the result is, in your neighborhood, people get remarkably different deals. Right. Depending on where you work, you can have a place that has amazing benefits, and you've never heard of a $3,000 deductible. That's crazy. You can't imagine it. And you'll be sitting next to someone who's like, $3,000, that's nothing. I got a $5,000 deductible. And I'm paying, this much. And it creates, I wrote about it as being, a little bit like we're all in an airport boarding line with zones 1 to 97. And, you're in zone 54, and there's some people from zone 71 who are cutting ahead of you. And you're like, what? That's not fair. Why do you get to go ahead of me? And then we get a politics that's deeply corrosive. It's deeply corrosive. Like, why do you deserve, dental coverage? Why do you deserve vision care? I can't believe we're giving those poor people who don't work dental coverage. I don't have dental coverage through work, So it's this deeply corrosive place in our politics. And I think that one friend, this guy Arnold Jonas I grew up with, he put it beautifully. He did not believe healthcare was a right. And he's one of the most, growing up in Ohio, you believe in self-sufficiency and that you are reluctant to impose on others, that you don't want to ask others for that. So he's one of those guys, right? He's never bought a car in his life. He has built every car he had from junkyard parts. He's got 3 functioning cars and 4 more in his yard that he mines for parts. And he's built them all himself. He owns his own home. He has never had a regular day job. He does construction work. He does pickup jobs and does art and design around the side. He gets dental care because he's dating a dental hygienist. And he says, the only problem is I can't date a dental hygienist and a cardiologist. And that's where his philosophy comes into it. He's like, I can build my car, but I can't build the road. I can own my house, but I can't count on, I need the help of others if there's a fire in my house. And we all pay in for my trash pickup on the roads, and we all benefit equally. And so his view of it is like, do I have a right to trash pickup? That just sounds weird to me. But we all pay in and we all benefit as equals. And the bridge that I found in the discussions across people, conservatives, and stuff, nobody was opposed to Medicare. And when I asked, why do you oppose Medicaid or the Obama expansion, but not Medicare? And, people on the left will make fun of people for saying, leave your hands off my Medicare. And the reason why, they know it's a government program, but it's different. And what's different is we all paid in with the payroll tax, and we all benefit as equals. Some of us are going to need a lot more of it than others. You don't know which way your dice will roll, and it's in that way like the other components of your trash pickup in your schools and things like that. We are still in a place where there are so many winners and losers that come from making the transition to saying, let's expand the number of people who might benefit. So there's 3 different ways we can expand towards a more universal future. It could be Medicaid for all, and there's a pathway that's developing that could be Medicaid buy-in programs and Medicaid for all, where it's more state-based. And Canada is really that. They are state-based, province-based care. The federal government chips in, but each state does its own thing within the rules of what the benefits have to cover. The second way we go is Medicare for all. Now, the interesting thing about Medicare for all is even today, it's half market-based.
Right.
So we've got 1/3 of people in Medicare who pick up Medicare Advantage plans. So they have an exchange, just like the Obamacare exchange, where you choose plans for coverage. And that's expanding. By 2020 or so, people are thinking it's going to be about 50% of Medicare.
And effectively, you're taking federal dollars there that you originally put in through your payroll tax, and then you're choosing how to spend it.
Where it's getting spent.
Right.
Or, we do kind of healthcare savings accounts for all, which is like Singapore. So there are, there are conservatives who would say, let's do healthcare savings accounts for all. There are countries in the world that have made every one of those models work. Our difficulties are so many winners and losers on our way to that pathway, because some places you have great benefits and it's working great, and Medicare is actually a step down from what you got. It only covers 80% of costs, doesn't cover 20%, and you're chipping in certain ways. So the transition issues, I do think that the pathway we get to is by expanding the number of people who can get access to one of these systems. And I'll say the last thing about the World War II point. The employer-based, I recognize I'm going to work for 3 employers who are committed to trying to make their system work well, and we can talk a little more about the nature of their population and why I find them so interesting. But the employment-based system of getting your healthcare coverage is breaking, and it's breaking rapidly. 94%, Larry Katz showed this, between 2005 2015, 94% of net job growth has been in forms of employment that do not have healthcare benefits. They are independent contractors, temporary workers, gig workers, you name it. You know, my kids coming out of college, these are the most likely jobs they're going to get are jobs where they're not actually offered healthcare benefits. And that is the world of the rapidly expanding world of employment. The number of people who have employment-based coverage is shrinking over time. So, and then even if you get that coverage, you're cycling in and out of those jobs faster and faster. We can talk about that more.
My prediction would be, I think we're most likely to go down the Medicare route. I'd be interested if you disagree, because Republicans haven't been interested in any 3, and Democrats have seen that the politics of Medicaid and the employer are much worse, particularly because some states will choose not to do Medicaid, right? And there'll be concerns about particularly people of color in red states like Latinos in Texas. And so I don't think the Bernie Sanders thing is likely to happen at all, because Bernie Sanders is basically saying we should take healthcare away from people who are happy with their employer-provided healthcare. I would be shocked if that ever happens. But I think we will see almost all of the Democratic energy to expanding healthcare access in the future be Medicare. I don't know if you think.
I think the energy be there, but you know, the core of it, the part that the Democrats don't talk about is we're reluctant to talk about the part of the equation that is the tax.
Yep.
That goes along with it, right? And the tax is critical because what people want to know is, are we paying in fairly? And what do we mean by paying in fairly? So, you know, if it is an add-on to the Medicare tax, okay, I can get that. But if you're talking about, look, this is already 18% of the economy. So if it's a 10% new tax, that's, you know, everybody's breaking out their pocketbook and saying, how does that compare to what I currently pay? And the problem is the people who lose are going to scream a lot louder than the people who win in that calculation. So a lot of it's about the transitions. So I think is likely to happen. There are 2 or 3 bills that have been introduced that are about Medicare buy-in, that you can buy in according to your income, buy into premiums, pay a premium and have Medicare coverage as an option that's open to you. And that I think being able to structure those options that allow us an expanding number of people under the age of 65 to get access to that as a option available to you as you cycle in and out of the various jobs that you have along the way. People need and want a place to come into where they can get coverage, where they don't have pre-existing condition exclusions. The exchanges have been this lifeline for an enormous number of people. You know, you look at the number of rules that are under the current plan. The ones that have been most appealing are the ones that feel really universal to people. You can't change now that your kids up to the age of 26 can get coverage on your family plan. That has been a source of more than 3 million people have gained coverage under that, and actually there's been mortality reduction that's come from it. So, you know, those kinds of elements that allow people to fall into a system where they can count on it, I think our transition issues are the challenge. We won't simply be able to say, overnight, we're getting rid of all employer coverage. Wait, you're getting rid of Kaiser? I can't have Kaiser anymore, or I can't have my primary care doesn't like this system that's working anymore. So we work through the transition issues through various buy-in options.
Let me ask you a mischievous question, given that you've devoted your life to healthcare.
Yeah.
Do we spend just way too much time talking about healthcare and health insurance? And so this would be the argument, right? When you look at the evidence, actually the things that makes people healthiest are not healthcare, right? They are things like education, actually, right? The more educated people are, they take better care of themselves, they have better mental health. And so one way to think about this from a kind of alternative history way is, obviously I think the Affordable Care Act was a great achievement, but there are times when I wonder, would it have been better if instead the Obama administration had said, we are going to take all this political energy and we're going to provide universal pre-K, and we are going to expand all kinds of public health things. And rather than trying to get more health insurance and thus more medical care to people, we're going to take those dollars and that political sweat and tears, and we're going to put it into things that I think might actually have better evidence of improving people's health and longevity. And to think of it going forward, should we be spending less time talking about health insurance and health care and more time thinking about these things that I think might actually have a bigger effect on people's lives?
So it's a great question, and I get to go full wonk on you here, which is perfect for the Aspen Ideas Festival, right?
Excellent.
So I got to do this very cool study, which doesn't get enough attention, so I get to talk about it.
Excellent.
With Kate Baker, who was an economist in the Bush administration, and Ben Summers, who was an economist in the Obama administration. And the three of us analyzed the data from the last 10 years, partly trying to answer exactly this question. And we said, when people gain coverage, what are they getting for it, and what's the cost effectiveness of that? So we looked at Medicaid expansions over the last 10 years, kids getting covered under the age of 26, Obamacare, other provisions that were added in, and all the evidence around it. And here's the story of what happens. Year one, there is a dramatic financial improvement in the financial health of the families. So bankruptcies rapidly go down. They get access to care and coverage, and they start being able to see the primary care doctor. They get more likely to have mental health issues identified, have blood pressure problems, a variety of things in the preventive space identified. By year two, they're under treatment. There is a 25% increase in the likelihood that they feel themselves to be in good or excellent health, and there is no mortality benefit at year two. And that data was then, used by people saying, why are we paying for all this?
Right.
Like, what's worth it? What's worth it?
Why don't we just give the money?
Yeah. Then we followed it out for 5 years. And at 5 years, there was a 6% mortality benefit. And the greatest gain, and now you understand why, was in people with chronic illness. So HIV, cancer, heart disease. And that's when we realized that, and then started looking a little more deeply at the data, that what we're really describing is something really important to understand about the human lifespan. When America was founded, the average lifespan was 40 years. In 1900, a century ago, Americans our average lifespan was only to our mid-40s. By the end of that century, we had discovered 70,000 different ways your human body can fail. You have 70,000 different ways your 13 organ systems can go wrong, different diagnoses. And we have discovered 6,000 drugs and 4,000 medical and surgical procedures, as well as a bunch of public health interventions that achieved that capacity that if you have a regular source of care, access to your needed medications and treatments, and you get the right care in the right way, you will live on average 80 years or longer. And it's a mix of the public health and the healthcare. In the last 50 years, almost all the gains are in the quality of life and length of life after age 65. And so it's a mix of those benefits. The further thing about that story of our life is that you realize there are phases to our lives. In your early years, you need some basic health care that's pretty cheap, but you need education and all of that early childhood education. And that's one needed set of universal things that human beings need across their lifespan. In your working years, we need solid infrastructure. So after you come out with your education, you need the roads and the digital access and all those things that allow you to enable your productivity and your contribution in the world. But somewhere around 50 years, you start to have your first major health episode. And our imagination is that we're going to rescue you with that episode and you'll be back to all good again if you just have some good catastrophic coverage. But that's not the real story. The real story is you do get rescued now that we've discovered how to do it, and you have a chronic illness now. And then you need care for that illness over time. It might be congestive heart failure or some kidney problems, or it might be chronic migraines. It might be any number of things. And then you have another episode, and now you have two, and then you have another, and then you have more. And life turns out to be the accumulation of chronic illnesses. It can happen on average at around age 50. But my son had it. He's a congenital heart patient, and he had it from the time he was born. 18% of us will develop a serious, well, actually it's closer to more than a quarter, develop a significant mental health issue, and that tends to happen before 50. And so, along the way, it's variable when these episodes happen. So, my short answer to you, what we found was coverage is highly cost effective, but it has the political problem of the benefit playing out over years. And we found a 1% increase in the benefit for each added year after 5 years that people gain coverage. And so it's like this over time. So same with education. The benefit is you put it in now and it comes out later. Infrastructure, you put it in now, it comes out later. And those are the really hard problems. These are the problems we have a hard time committing to politically. But we found very high level of cost effectiveness. Like environmental regulations, we find life-saving benefits from those at about a cost of $6 million to $7 million per life saved. This is well below a tenth of that per life saved. And there are public health benefits from some other things we can do, but we just have a hard time doing any of it.
But so in a way, you're saying no. You're saying that, yes, maybe we should also pay attention to these other things, but we should not feel insecure about the amount of effort and energy that we spend on providing more people with health insurance.
Strong evidence that we're talking about tens of thousands of lives saved. Even more importantly, not quantified in the calculations, because we just looked at lives saved, is substantial 1/3 reduction in depression when people get the coverage. Substantial improvement in their financial condition, marked reductions in bankruptcy. So I think there's pretty strong indication that we get a lot of benefits out of having universal health care coverage. And it has to do with taking a lifespan view of what we need in multi-generationally, that we all have to be helping across. The thing that drives me most crazy in the debate is I don't need, I'm 50 years old. Why do I need to cover pregnancies? Or why do I need to cover pediatric care? That's not my problem. Those same working people are, as we go from 6 tax-paying workers for every one who's retired down to 2 for every one that's retired, and by the way, the majority of those will be immigrants and people of color, we have to care a great deal across generations about what happens to people in their education and in their health, as well as in our communities.
So there's a roiling debate that's been going on for a long time among health policy people about what is a bigger problem for our healthcare system. We famously have the most expensive healthcare system in the world by far. It does not have great results through much of the system. Is it a bigger problem that we do too much treatment, right? That we're too quick to give prostate tests and breast cancer screening tests and have the most advanced lasers that try to fix our bodies? Or is the problem that all of our prices are too high, right? Uwe Reinhardt, famous late health economist, has an article, It's the Price is Stupid. I'd be interested in your thought. Do you think both of these are major parts of the US cost problem, or do you think one of them dominates the other?
It depends on the question you're trying to answer. And I go a little crazy at this debate because if the question is the U.S., what makes the U.S. different and more expensive than other places? Prices and administration are the story. We have a more bureaucratic system because of the ways that, we've got all these multiple systems that are trying to interact with one another and the prices. But in the Ariadne Labs, the center that I run, we do healthcare experiments trying to improve outcomes of care, whether it's in surgery or childbirth or in end-of-life care in the U.S., but half of it's abroad. And healthcare is crap everywhere. We have the biggest body of problems is, do we provide the right care at the right way at the right time every time? And the answer is no. Lack of execution is a fundamental problem. An example, Tom Frieden talked about at Spotlight Health. In the United States, only 40% of us have our blood pressure recognized and under control. It is probably the biggest killer in the country. Cardiovascular disease is our biggest killer, and smoking is down, so now high blood pressure is our biggest opportunity. And we only have 40% of us who are receiving the appropriate care and have it recognized and under control. In single-payer systems abroad, they're the same. Britain's actually worse. You have no country that's over 50%. Worldwide, it's 1 billion people in the world have high blood pressure out of 7 billion, and only 14% have it recognized under adequate control. And the control of it is cheap. We're talking about 1960s technology, pennies on the dollar to be able to take care of it. And we don't deploy it and take care of it properly in the least. We spend, the number one spend in, we spend, our biggest category of spending is on surgery and other procedures. That's the biggest category. And the biggest spend within surgery is on spine surgery. We've grown spine surgery 4 or 5-fold over the last 15 to 20 years. No improvement in disability. No reduction in disability from back pain. So you ask the question, is the problem overspending, overtreatment? Is it too much of, it's the wrong treatment. Our problem is we have the wrong treatment. We do have a problem with prices and administrative costs. And part of tackling this, part of what I'm really looking forward to with this new job is you have leaders who are willing to put in the resources to say over a longer time span, 10 years plus, that we can correct and go after all 3 of these problems and create scalable approaches for each of them. In our work, in surgery, for example, we've scaled a simple checklist. I went really low tech because we're a small public health organization. What can we do? And we created a checklist that we've now bought the medical profession into using around the 19 most important things you can do during surgery to avert major problems happening. And we got the results back after 5 years in South Carolina. The hospitals that implemented it, represents about half of the population, have a 22% reduction in death, lower costs, in fact, almost $70,000 less costs for every complication averted, and we're saving as many lives as died in motor vehicle accidents in the state.
Wow.
And so, it's feasible to do these things. It's often not sexy, but you can make a very big difference.
Last question from me before we open up. It seems to me that clearly that Amazon, JP Morgan, Berkshire venture that you're now going to be running, that part of it has to be expanding these kinds of things, right? Trying to avoid the wrong kinds of treatment, trying to reduce medical error, things like checklists. But it also seems to me, if prices really are a problem in this country, and they are, that some of it is actually in some ways simpler, but blunter as well, which is you are combining a whole bunch of workforces, and what you need to do is try to take the economic power that comes from those workforces and say to hospitals and to doctors and to pharmaceutical companies, you're charging us too much. Am I right about that?
Yeah. I mean, there's 3 things that I pointed to in the middle of all this, all of which, so the excitement to me is, sure, I love the idea that I'll be working with these incredible leaders, Jeff Bezos and Warren Buffett and Jamie Dimon, but what they're giving me is the chance to have 1 million new patients. And those patients are really ordinary America. The biggest workforce for Amazon is fulfillment center workers who usually are cycling about a year or so in and out of their jobs and have very unstable coverage over the course of time and bring many problems into getting coverage. On the flip side, you have Berkshire Hathaway, which are some of the oldest line companies around, like Burlington Northern Railways. I mean, union workers by the hundreds of thousands who are on the job many years, typically over a decade, and they're older and have accumulation of chronic illness and don't have good primary care. And then you have Chase Manhattan Bank, where their biggest JPM is, their biggest employment base is bank tellers who are making less and less money and have a variety of issues. It's sort of, like the 40th and 50th percentile of America, and how do we solve problems when they're not in Medicaid and not in Medicare? The leverage of having them all together and in a nonprofit where it's very clear we're only there for the benefit of the patient and no money goes back to any of those companies out of the investment. The result of that is that you can go in and say, we can't be providing care that has no benefit to people. You can begin to create solutions around how do we take out middlemen who had no value, and how do we have leverage on the prices. And I think it's a test of whether pulling all those people together allow us to take on those kinds of problems.
How many employees do you think the nonprofit will have?
Well, I mean, these companies as a whole have 1.2 million.
No, I'm sorry.
Yeah. I have no idea. A lot of it depends on how much of it we want to do ourselves versus through partnerships, and so I won't have an answer to that for a few months.
Fair enough. Okay, questions from you all. Way in the back there. Please tell us who you are and give us a nice, crisp, quick question.
In the form of a question, even.
My name is Ganesh, and I'm doing entrepreneurship in masters. And I have a question like, what are the next big things that startup should focus in healthcare, so that what you are doing, we can achieve the same thing by doing the startups, like reducing the cost and having the big impact?
Yeah, I think we've come to a place where the biggest growth, a lot of the startups in healthcare have been traditionally focused in biotech, but we're seeing now a growth in startups, both nonprofit and for-profit startups, around solving these core problems through scalable means, better outcomes, better delivery and experience of care, and better cost efficiency. And so, there's interesting ones that range from, the really mundane things. There's one called Kairos in Boston that is online scheduling for all of your appointments, and being able to make it so that's like the Sabre, like you can easily schedule and find airline flights. Why is it impossible to get a primary care physician? And just trying to find it, it's just impossible. And so tackling these really basic things that have enormous leverage, huge transaction costs, are, but it's really deeply understanding. What people haven't done is walk in the shoes of patients and get close enough to what that experience is. And it's because a lot of the entrepreneurs, are 24 years old. And they don't know what that experience is like when you're 55, 65, 75, 85, and have many problems that you have to solve that the current system doesn't provide ways to do it. And then you add the complexity is it has to be able to be delivered by the clinical workforce and the patient working together. So it's a really hard space. But the people who have found, narrow in on a very defined major pain point. At Ariadne Labs, we just tackled 4 of them. We tackled birth and how we have, in a place like the US, 1/3 of all births are by surgery, by C-sections, when it doesn't need to be half of that. And so how do we change that? And we're deploying and testing in Oklahoma and in Massachusetts, and it'll be in other sites soon, approaches to solving that. But, I talked about surgery. In end-of-life care, what we found is in fact larger than end-of-life care. It has to do with any point at which your quality of life might be affected by your illness. The most powerful thing that lowers costs, improves the quality of your care, and improves your patient experience is that we need to have a discussion between clinician and patient about what your goals and priorities are for your quality of life and not just your survival. But we don't have that conversation. We have that conversation less than 1/4 of the time before you even come to your death, let alone upstream when your treatment choices and things should be part of that equation. And every time we have those conversations, the result is lower cost because people get less unnecessary care that's not aligned with what matters to them, and you get more of the things that are actually beneficial for you. So it's those kinds of, it's zeroing in on these very powerful, high leverage, but important aspects of care.
It reminds me of a point you've made in the New Yorker years ago, that you thought many of the gains for well-being wouldn't come from bench science, but that they would come from what seemed like pretty basic execution of the delivery of healthcare. And that's still the case.
Yeah, to me, this is like the most important thing to understand. Most of human history, our major problem was ignorance, and we didn't have, we've been applying science to the discovery of what are the problems in the world and how do we tackle it. It might be how do we drill for oil? It might be how do we now replace oil as an approach? Like there's a lot that's in the realm of ignorance. We still don't know how to solve Alzheimer's disease. We don't know how to solve certain kinds of metastatic cancer. But I described that, we have this armamentarium now. And for the first time, we are a generation where equally big or more powerful is the failure to solve the problems of execution.
Yep.
And as a generation, that making systems work is actually our most important thing to take on, whether it's what we know works about education, what we know matters about energy and climate change, and what we know actually saves lives and improves health in something that's eating a fifth of our economy, which is healthcare.
We had a question down here.
You like going all the way around the,
Yes,
the
exactly.
room.
I'll preview the third question. I will call on a woman.
My name is Chris Gates, and I'm one of your 1.2 million new patients because I'm at J.P. Morgan.
All right.
And David, you'll forever be one of our favorite seminar leaders and moderators. Thank you. My question has to do with how this whole idea came together, and it may have come together because they contemplated that there was someone like you out there. But what I'm really interested in is how these three different organizations thought about this public policy idea in what seems to be such a generous and useful way, and whether or not that in itself is a model for other organizations and institutions to sort of combine and think about things that we may have traditionally assigned to government.
Yeah, and I hope it's the beginning of these three coming together, and then as we find solutions, being able to pull more in. I still have to learn more about the whole back history. What was clear from my discussions with each of the three of them is that emotionally it started in a place of being pissed off.
So many good things do.
You're right. And it's that they have squeezed the living daylight out of every item on their balance sheets, and then there's this thing ballooning in the middle of it that they felt they could do nothing about. And however much they were spending, everything that they saw told them that it was that they weren't getting anywhere near the dollar value that they were putting in. And so if we have 18% of the economy going in, and we know 30% is not adding value and may even add harm, you're only getting 12% of the economy's value out of it. And so their view is, well, either just get down to just pay the 12% or lift up to let's get 18% worth out of it. But one way or another, it seems untenable that they would have this whole major part of what's happening with their employees and that we wouldn't do anything about it. Then furthermore, that we as a country, we're not doing anything about it. That here, the passage of the ACA represented a moment where we were moving forward on tackling these problems. And it became very clear we're abdicating that now. And I think they did it out of a strong sense of responsibility. That if the government was abdicating, if the ordinary American couldn't wield their power and influence, that in each of their three stages of life, that they were going to double down and solve this. And they had an employee population that they were responsible to, that they were just not going to let that go. And they didn't think this was only about their employees. It was very clear from the conversations. That gives them that is their reason to be in it. It gives them their credibility for wanting to be in it, and gives the place that we can begin to experiment, but needs to be about solving this when other people are walking away.
Can we have one last quick question? Right here. Thank you.
Thank you. Hi, I'm Christina Cotterucci. I'm from Slate. I write about women and gender, so reproductive rights and access is a big beat of mine. I know in that space there's the moral human rights framework. Women deserve to control what's going on in their bodies. There's also the argument advocates make from the economic point of view. Abortion and contraception access is a great reliever of poverty. And I'm wondering which you think is a more compelling argument for people, maybe some of the people you talk to in Ohio who might not be on board with universal health care. I've been wanting to see more arguments from the human rights perspective that, poor people don't deserve to die because they're poor. But a lot of the arguments that have been made have been from the economic standpoint of, if we invest now in healthcare for everyone, it'll be cheaper in the long run. Have you heard any good arguments from the moral human rights point of view?
Yeah, so the thing that struck me, and I didn't write about it in the piece, was that the rights conversation is perceived, is felt by those folks who are the tax-paying folks who are struggling at the same time to be a discussion about what can you demand more from them? That a right was not a benefit to them. A right was something that was being demanded of them. And it reminded me of the gay rights debate and what a change happened when we went from saying that the fight for gay marriage was a fight for marriage rights to saying it's a fight for marriage equality, that we all deserve respect and dignity as equals. There's a certain fundamental way in which the anger stems from feeling that that my friends back home who don't have the same economic opportunities have been written off, that because they don't have that college education, that they are not the future of the economy, that there is no place for them. Oh, but you have to pay the taxes for everybody else. For example, we talk about we ought to have a right to a college education, and therefore the government should pay for college education. And they say that's just another thing I got to pay for. I'm not going to benefit from that. My kids are not going to benefit from that. That's going to be paying for that upper 30% all over again, and that's not going to work. But when you talk about the idea, that Jimmy Kimmel or anybody else talks about, your child can have a condition like my son does, where he's now got a pre-existing condition for the rest of his life. He has a congenital heart condition that makes him uninsurable. And we can't have a place where he can't obtain insurance. And that could happen to any of us. That in fact, it will happen to all of us at some point in our life. We will all become sick. We will all become vulnerable, and we will become uninsurable. We will develop our chronic illness. And having that capacity to believe that we are all have an equal shot at having the coverage that matters to us, those are the things that felt like the bridge along the way.
I encourage everyone to read the article. It's available online, and it unlike most articles, it includes a scene in which Atul talks about one of the people he interviewed bench pressed him years ago. So you don't get it. We're obviously all excited to see how you take these ideas and try to put them into practice at the new venture, and thank you for talking with us.
Thank you, David.